Hello, everyone. Welcome to addressing the pervasive burden of delayed identification in disease. We're going to wait just a minute or so to give some time for some of our members to join. For those of you who are already here, thank you. I think you're in for a very exciting conversation. Hopefully, I'm going to repeat this later on, the blueprint for the future of cardiac care. This is a great case study coming at you shortly. Give it another couple seconds, and then we'll jump right in since we have a lot of content to go through. So, happy Thursday, all. We're almost there. So we have some really great guests today. We have Dr. Ebinger, the one and only from Cedars-Sinai, who's just coming off paternity leave. So we're incredibly honored to have him here with us so early on. Kirti, who is critical to this because he's Epic and not Epic from Wisconsin, Epic from Cedars. So that's really an important detail for you guys, right? Because he's going to teach you just enough uh, educate, give you just enough education to make you dangerous when you go back to your own epic people and tell them that you would like to do the same thing. And then of course we have Rakan Khaki from Biome. For so those of you who don't know about Biome, you're in for a big treat today. We've learned a lot through this case study working with them. And I think they're an amazing tool that again, you will learn a lot about shortly. And again, they're a cloud-based system, and you can never have enough quality data. So with that, let's jump right on in. So disclosures, nothing exciting for the majority of us. Dr. Ebinger has some grant funding from Edwards. Um, Housekeeping, general housekeeping. You guys know the routine, right? So to the right, send text questions to the presenter. We will try to address those if the opportunity presents during the talk, but if not, we will definitely get to those at the end. And then to the left, the blue link, you'll find a link to access the presentation slides. Again, the webinar and the slides will live on, so hopefully you can use that as a reference point going forward. So I'm going to give you just a quick couple bullet points to set the story up. The why, right? So we're going to talk today about this. I'm calling it this funnel, this really big funnel that keeps growing and growing, right? This patient funnel that, lots of patients and the process of getting them to the cath lab, to the EP lab is getting more and more difficult for a number of reasons that aren't always in our control. So today we're going to, again, talk about the big industry trends, the technology, which is critical. In this case specifically, EHR, right? Which you guys all got one of those. So coincidentally, we're going to, dwell on that a little. The clinical realities of the patient, the practical application, and finally the outcomes, right? Standards of care with this case study. That's a great example. And again, I'm going to call it the blueprint for the future. So we know industry-wide, we're all data rich. We see it all the time, but we're insight poor. We have the privilege of seeing our members going on site around the country, and we get lots of data, but the quality of it is often poor, right? So today we're specifically going to talk about structural heart programs, but the reality is this is for all projects. This is for all programs, right? From general cardiology practice, inpatient, outpatient, all facets of cardiovascular medicine. But in this case, we're going to talk about structural heart programs, how they're growing rapidly, right? Which is a good problem, but we can't keep up with them clinically, operationally, and financially, right? Especially as clinical guidelines keep changing. For some of those who have been here for a while, the criteria for a TAVR patient was this big, right, when we started, and it continues to grow. So again, it's this funnel that keeps expanding, and how do we get to the patients to the right place at the right time? So for those members, thank you for your membership and your participation today. You guys know our philosophy. We champion operational efficiency, right? It's at our core. So this story is the epitome of everything that we value, right? The smart business practice that drives clinical, operational, and financial excellence, right? We all know that there's a ton of technology out there, but guess what? If we can't get it to the patient in a timely manner, we have failed our patients. So this is a perfect example of how we bring together resources that are already there and maximize their capability. So with that, we're going to jump into how Cedars-Sinai leveraged Epic and Biome to close the care gap, and how this architect, again, hopefully transform the way we identify and treat patients going forward. So with that, we're going to jump right in, and I'm going to introduce Rakan, who again is the not only co-founder, but the COO of Biome. So welcome, Rakan.
Thanks so much. So I'd like to start off with a few slides with a bit of background of who Biome is and what we do. So in programs across the country that we work with, we know that cost pressures are incredibly intense and only getting more intense. And administrators, they're accountable for margins. Physicians, they're accountable for outcomes. And oftentimes, those two sets of people are looking at completely different data. So clinicians, of course, think in terms of patient risk, procedural complexity, real clinical nuance. And the administration is typically working off of billing and cost accounting reports that were built for reimbursement and not clinical accuracy. So those reports often miss the nuance and over-exaggerate and aggregate procedures, or they layer in indirect costs to make the analysis pretty hard to act on. The biggest roadblock is physicians getting their data analyzed without the risk profile of their patients coming into account. And that misalignment creates mistrust. And that's the gap that Biome closes. We integrate clinical and financial data into one single and administrators can look at the same paper. There, we do four things. First, we identify the high yield quality improvement projects that reduce costs at the same time. Second, we create operational capacity. When complications decline and processes standardize, you free up beds, you free up lab time, and quality improvement helps support growth. Third, we improve documentation and risk capture by aligning registry and coding data that strengthens benchmarking, but also can improve revenue. And then fourth, margins improve as a result by reducing waste, preventing complications, and aligning clinical excellence with economic discipline. So at its core, we help administrators and physicians really speak the same language. And when that happens, performance improvement becomes measurable, it becomes aligned and financially meaningful. Next slide. So I'll go a little under the hood to show you how it's done. We integrate two data streams that you already collect at your institution. The first data stream is your administrative and financial data. Now, this information gives us social determinants of health, billing, coding, direct and indirect costs, contribution margin, and other financial metrics. The second stream of data is your national registry data. These are your gold standard STS, CAF PCI, TVT, the risk-adjusted and clinically adjudicated high-fidelity data. And the physicians trust that registry data being input. They're adjudicating this data. It's their data, and the only thing that they'll push back on is its interpretation. So we unify these at the patient at the procedure level. So now you're not only looking at these data sets in isolation, you're actually just looking at a single coherent view of your performance. And that alignment allows us to identify real variation and prioritize high impact projects. And most importantly, this is 100% cloud-based. It has no Epic integration, no EHR integration. So very fast time to value. Now, the solution itself is broken out into a suite of products. It's not just dashboards, it's a comprehensive structured performance improvement product, which is really meant to guide you through the entire performance improvement lifecycle. I'll walk through the three core tools and jump into the fourth tool, which is the echo surveillance, in a later slide. So first, you see the opportunity engine, the first column there. That automatically surfaces where meaningful variation exists inside your program. It uses AI and machine learning and is powered by more than 10 years of clinical context and measured curation from our team. So it knows which subcohort matters and which stratifications are clinically relevant. So instead of asking, where do we focus, the system actually automatically shows you where the highest yield opportunities are. The second tool is the analytic engine. That allows you to explore the opportunities in a really disciplined way. You can drill into risk-adjusted subcohorts, procedure types, data by provider, and detailed cost buckets that are all properly stratified. Then we move into the performance manager, and this is really where we differentiate. Most platforms stop at just showing you how you perform against peer institutions. In addition to doing this, what we do is we actually quantify the return on investment of taking on different quality projects. The product is configured like an automated A3, which tracks initiatives, allows you to set clinical and financial targets, and assign ownership and track progress. So as you improve, the system calculates contribution margin impact in real time. So you can actually see the cumulative financial ROI of all the quality improvement initiatives. And this is really important because programs always want to grow. Oftentimes, however, administrators are stuck with making a decision on growing a negative margin program. But when you have Biome and when you reduce avoidable complications and improve documentation, standardized care pathways, you don't just lower cost, you optimize your margins and you create capacity. And that growth comes from eternal efficiency. So improved quality creates capacity. Capacity supports growth. Growth increases your contribution margin. And then oftentimes that margin can get reinvested back into your program. And that's the ROI flywheel that we've created within this tool. Next slide. Now, one of the biggest advantages of linking your billing and coding data with your registry data is pretty simple. You can actually quantify the incremental costs of undesirable clinical events. This example comes from a paper that we co-authored with a customer examining the direct costs across the TAVR episode. When you match the economic and clinical data, you could see exactly how much margin is lost per event. For this presentation, I'd like to focus on the urgent TAVR versus elective TAVR. In this specific analysis, the urgent TAVR carried one of the largest incremental direct cost differences compared to the elective cases. So when hospitals can see measures presented in this way, they know exactly where the financial drag exists within their program. And this allows you to turn quality and process improvement into a business plan to drive positive margin into your program. Next slide. One more critical point about our ecosystem is that Biome isn't just technology and products. It's complemented and coupled with a performance improvement team that's made up of subject matter experts, who have led cardiovascular quality initiatives, who actually align themselves with the success of your program. They don't just hand you dashboards. They help you frame the right questions. They pressure test hypotheses. They bring pattern recognition from working with top programs nationally. And this is really where we're uniquely differentiated, because we are bringing playbooks that have worked at other high-performing structural heart centers. And after analyzing your data, we tailor those playbooks to your specific data, your specific patient mix, and your specific operational realities. So the technology surfaces the opportunity, and our team helps you operationalize it. Next slide, please. And the reason we consistently drive ROI is that our technology is built on a disciplined, scientifically grounded improvement method. We call it the impact model. And what this does is it aligns with established performance improvement principles, but it's fully operationalized within the technology in our platform. The technology guides you step by step. It automatically surfaces your top opportunities. It maps your program landscape. It quantifies true performance gaps using risk adjustment and subcohort analyses. And it helps you build a defensible and data-driven action plan. Once we work with you to establish that plan, we engage every stakeholder, assign ownership, and then we execute on that plan. And that's all tracked and managed within our products. Next slide. So now I'll jump into the fourth tool, which was in that earlier slide, which is the Echo Surveillance Engine. And now we built the Echo Surveillance module at Biome because we recognized something that was really important. For our customers, we knew that anecdotally there was significant latent demand for therapeutic intervention for patients with valvular heart disease. From a process improvement standpoint, mining the echo data to identify those patients earlier made perfect sense. So we went on and started working on this. But then in reality, we found that there are multiple competing pressures within the hospital. The resources are constrained. Sonographers were in short supply. And accreditation and quality standards require a lot of administrative effort. So under this intense resource constraint, most systems just don't have the bandwidth to manually sift through that echo data at scale. So we built a system that automates that work. Next slide. The Echo Surveillance solution was built around a clear triple aim. Oh, sorry, Anna, next slide. And there we go. Thank you. I'm seeing it now. Yep, perfect. So just as I was saying, the Echo Surveillance was built around a clear triple aim. First and most importantly is the active echo surveillance. That's the primary use case. It's used for identifying patients with native valves who have not been evaluated for treatment within your system. And the goal there is to really help drive timely and appropriate intervention. The second principle here is operational performance. We provide you with structured reports that help manage workflow, efficiency, and optimize resource allocation. Third is the quality and accreditation. So we generate quality and reliability measurements that are aligned with IAC accreditation standards to help support things like maintaining your accreditation and improving measurement consistency. So it's not purely just data mining, it's patient identification, it's operational control, it's quality compliance all in one system. Next slide. All right, so how do we get to this? So our incredibly talented engineering team led by Matt Esham, who's our VP of Analytics, brought this solution to life. And Matt, the reason I bring him up is a bit of a unicorn because he has deep expertise in cardiac ultrasound, he knows how to code, and he has deep registry domain knowledge. And that's the kind of sophistication that really matters when bringing a solution like this to life. It's not enough to just simply parse through the echo reports. The echo data is largely unstructured. It lives in narrative text and contains multiple measurements, sometimes conflicting statements. And so what we built is a semantic natural language processing, or NLP engine, that ingests every echo report across your system and converts that unstructured narrative into structured, clinically ranked data. It doesn't just extract the numbers, it actually understands the context. It maps that unstructured and structured data together through a series of over 60,000 rules that continue to grow as we encounter new edge cases. So the result isn't just a text parser, it's a clinically intelligent surveillance engine. Next slide. Now, this is just a look at the system interface. At the top, you'll see quantified severity distribution. So within seconds, you can easily understand how many patients with native valves fall into these clean categories of mild, moderate, or severe across your system. We also show study tracking to see how many patients require a new review, have been referred or scheduled or declined or awaiting provider response. And then below is really kind of the core that filters into the workflow piece that we're going to explain in the subsequent slides, where every patient is a sortable, filterable, and searchable patient in the case list. You can see the quantified findings, qualitative echo interpretation, referring provider, study date, all in one place that will then you can export and feed into that workflow as a clean list. Next slide. So I'd like to pivot with that background to the clinical urgency behind everything that we're talking about. When treatment is deferred and patients ultimately present urgently or emergently, the outcomes deteriorate. And you can see that in the figure on the left as well as the table to the right. In-hospital mortality nearly doubles. 30-day mortality increases meaningfully. 1-year mortality approaches 30% in urgent or emergent cases, and the length of stay doubles. Now, when we talk about echo surveillance, early identification and operational discipline, that's really the why. If we can identify severe disease earlier, if we can prevent patients from falling through the cracks, if we can move cases from urgent to elective, we simultaneously improve outcomes and improve margins. Next slide. This slide brings together the economic story into focus around this problem set by using Biome's de-identified national benchmarking database. You'll see that an elective case averages about $46,000 in direct costs on average. An urgent case nearly jumps to $73,000, which is about a $27,000 difference, which represents a 59% increase. So when we talk about early identification and preventing treatment delays, every patient we can appropriately move from urgent to elective represents a significantly meaningful margin protection. And this is really the overarching story. Quality and economics are not competing forces. When they're done correctly and analyzed correctly, they're actually pretty well aligned. And that's Biome's entire thesis. And that alignment is exactly what our platform is designed to enable. Next slide. So I'll end this portion with a real case study. At a single center, we processed over 26 million rows of echo data across 185,000 patients over 2.5 years. Within 2 weeks after our model was trained, we identified 6,500 patients with untreated aortic stenosis, over 2,200 of which were moderate, severe, or critical. So these patients were already in this hospital system. They had been already imaged, but not systematically surfaced. Next slide. So I'll end with this. In today's environment, quality improvement alone isn't enough. Because of cost pressures, every initiative has to demonstrate an ROI. And this is why our platform is built differently. Because we're integrating that economic data directly with your clinical data, the system automatically generates a running ROI of your efforts. So you're not waiting months down the road to be able to estimate the impact of your quality improvement initiatives. You're actually tracking the contribution margin improvement in real time. So for this case study, within just 8 weeks, we'd identified there was 200 additional candidates that were screened for TAVR. Over 40 of those additional TAVRs, excuse me, of those over 40 of those 200 patients were actually candidates and had a TAVR procedure after they were identified. And the important piece here is 100% of those patients, when we tracked them through the process, were elective. And because of that piece, the program generated over $1 million in added margin. And that's the full story coming together here. We have early identification, we have timely intervention, which then leads to improved outcomes and ultimately higher contribution margin, and the measurable ROI to justify that reinvestment back into the program. Being able to report this data in this way creates a disciplined, quality-driven growth, and that's the Biome model. Next slide.
Sorry, not sure what's happening there. All right, next we have Dr. Ebinger, who will, the clinical realities, right? How this, the why really, right?
Exactly. Well, first of all, thank you everyone for attending today. We're really excited to share this work. My name is Joe Ebinger, and I run our clinical analytics program for the Heart Institute at Cedars-Sinai. And the reason that I'm in the middle between Rakan and Kirti is because they just try and shove the dumb guy in the middle. I'm here to really provide some of the clinical context that really the incredible computational and analytic powerhouses that our IT services led by Kirti and our Epic team and Biome helped us realize. And so what I want to start with is from a cardiovascular perspective, why did we start focusing on valvular disease in the first place? And well, frankly, there's an impending tsunami. This is data that was recently published in Nature, one of the Nature Review journals, looking at the overall prevalence of valvular heart disease globally. And I don't think it takes an MD to realize that those numbers are all going up. And what you're seeing on the left is the absolute prevalence, looking at total and then rheumatic and non-rheumatic. But look at the graphs that are the maps that are on the right. You see calcific aortic stenosis and degenerative mitral valve disease. These are diseases that are not just occurring globally, but particularly occurring in high-income countries. As our population ages, we're seeing larger and larger burdens of valvular heart disease that need treatment. Surgery is no longer the sole answer. But on top of that, being able to identify patients who may not otherwise have been screened, recognized, diagnosed, and appropriately managed becomes a population health issue. At Cedars-Sinai, we're a large integrated healthcare system in Los Angeles, but this holds true whether you're in the middle of LA or you're in the middle of Louisiana. Being able to take care of the patients in your community and identify them early is the best way to improve their outcomes and help healthcare systems help the communities that they're designed to serve. Next slide, please. So, why is it important to be able to act early? Why not just wait until a patient shows up with symptoms or something happens and we bring them in? Well, frankly, this is a morbid disease. Rakan laid out perfectly why it's important from a health system perspective to do this, and we can all think of clinical efficiencies and bottom lines to do it. But I really want to bring it back to the patient. When we look at the number of deaths, just raw deaths that are occurring from valvular heart disease, in particular aortic stenosis, so this is non-rheumatic valvular disease, those numbers are going up year over year. And why is it? Well, it's because of the classic figure that you see on the right. This is a figure that I think anybody from medical school will remember. Once patients with aortic stenosis develop symptoms that prompt them to seek care, their risk of mortality over the next 2 years is extremely high, in particular if those symptoms are things like heart failure. So seeing a patient who presents already of shortness of breath, and they had an echo that demonstrated aortic stenosis years before, we're on the clock. And in fact, we're behind the 8 ball. The reason that we wanted to bring this into fruition is because we are very cognizant that once we hit that symptomatic point, we really have to be reaching out to patients and get them to treatment soon. We also are cognizant that valvular heart disease is not the only thing on the agenda for healthcare systems, let alone cath labs. And how do we ensure that we are able to effectively leverage the space, the capacity, the resources that we have to care for not just our valvular heart disease patients, but make sure that we're providing care for everybody else who comes through our doors? Next slide. So, how do we do it? Well, these are pictures that I think anyone who's had a clinic will recognize. Computer in every single one of them, whether you can find it buried under all the things or not. EHRs are super helpful, but we still in healthcare far and away track these patients through sticky notes, through boards, through email systems. There isn't yet, until Kirti describes what we've done, a unified mechanism for tracking patients through this. Additionally, valvular heart disease care, unlike showing up to your doctor for a cough or a cold or coming in to do your annual physical, this is a continuity process. This is an entire journey that patients have to go through. It is not solely show up to the hospital, get your valve procedure, and go home. The amount of care required in preparation and evaluation, the actual procedure itself, and the long-term follow-up care to ensure that they're being screened and monitored appropriately in compliance with STS and TVT regulations is really hard to do. When I first was asked to look at this within our system, I went and did some walkarounds in our clinic with our APPs who help to care for many of these patients. This picture is superimposable on what their office looked like at the time. Patients were being tracked on Excel sheets, on printouts, on sticky notes, on color-coded boards that really hadn't been updated in a while, which led to patients falling through the gap or falling through the cracks. What did this mean? Patients presenting for care and they were missing aspects of their workup. Patients who had delays in care, patients who didn't know that they were scheduled and thus leaving empty spots on the board, and then patients who were lost to follow-up only to present a year or two later, realizing we never got a follow-up echo completed or a KCCQ and alike. We looked at this and said there has to be a better way in 2026, and how can we leverage the tools that we have in a low cost, low profile, easily generalizable platform to be able to go out and improve care for all patients with valvular heart disease, which is a perfect segue into our light bulb moment. Speaking with Rakan and with Kirti, we realized that we had ample amounts of data. We were data rich and, as Anna mentioned before, insight poor. Between our siloed registries, which included our echocardiovascular system, our database registries, and our electronic health record, all the data we needed to be able to first identify these patients who had had an echocardiogram but weren't yet brought into care, and simultaneously being able to track patients through their care pathway existed, but there was no system to bring them together to allow this to be done in an efficient fashion. We sat down with Biome, with our IT team, including our Epic expert users and developers, and importantly, absolutely importantly, with primary cardiologists and cardiovascular providers who are caring for these patients. And we said, knowing that all this data exists, what is it that you are missing to get to the right side of the screen, to get to the patient being treated in a timely, efficient manner that both improves quality and ideally reduces the burden and cost that goes into caring for patients currently? The first phase of this, Rakan already described, and we worked extensively with Biome in the development of an echocardiovascular screening tool. And where Kirti's going to bring to next is how we took all of those sticky notes, the Excel files, the mounds of paper that existed within our office, and brought those into the electronic health record so that they could be tracked longitudinally, lists developed, and patients have high quality, efficient care that ends up with better outcomes, not just for the hospital, but most importantly, for those in need. With that, I'm going to pass it off to Kirti, who's going to talk about the second half of how we were able to do this using Epic. Kirti?
Hello, good afternoon, everyone. Thank you for being here. I wanted to take a quick pause and just ask our audience, how many of you, and feel free to use the raise hand feature in Zoom, how many of you have an existing structural heart program and find yourself struggling with similar problems that Dr. Ebinger just mentioned? All right. I see some shy ones out there, but glad to know. um, Part of our challenges was also not just the sticky notes and the Excels. We were also wondering how can we better get metrics on our KCCQ and TAVR procedures and whatnot. And it all came down to data. As Dr. Ebinger mentioned, we already had an EMR which has everything stored in. And so why not look into Epic? Epic has a native tool in their foundation systems called the patient tracking tool for structural heart. It's a combination of different features within Epic. And we thought that this would be perfect to explore in this case. Next slide, please. Now, why is it perfect? As I mentioned, referrals, appointments, clinical notes, procedures, orders and results, labs, all of these already exist in Epic, and we just wanted a one-stop shop, one place to look at this information in a collective view. Part of the tool from Epic focuses on using episodes and smart forms, checklist tasks, and dashboards, some of these which I'll expand upon in the following slides. Next slide, please. Let's talk about the smart form. From right off the bat from Epic, we get a basic form that just documents stuff like, okay, what was the referral date, any procedure date, consult date, is the patient ready for intervention, or additional labs and testing needed. So we kind of kept some of those things, but at Cedars, we have a lot of volume. We have a lot of demand. Our caregivers really like to go the extra mile. And so we thought we needed more, we needed to track more, we needed to be more discreet. So we created additional fields such as the diagnosis that directs what type of planned intervention we can subscribe for the patient. And because we also take part in many research trials, we added an additional component to indicate if the patient was waiting for any trial confirmation. If they've already been screened for trial, what are those trials that they're already been screened for? And we also have the smart form built with additional scripting. For the scripting, and I apologize if some of the folks are not here that don't use Epic. Scripting and smart forms are a bit more advanced tools, and I don't want to be technical on this call, so I'm just going to use some layman terms. The scripting helps us avoid misdocumentation. Part of just digital documentation is avoiding the incorrect documentation, because that's a lot of headache to clean up. So part of the scripting is if you click TAVR, you only get TAVR related research information. If you click TMVR, TER, you get those particular information displayed to you. So that's one of the advanced tools that we built upon with Epic. And then the last and the most important one was tracking phase. Now, what is a tracking phase? When we spoke with our caregivers and we looked at the data, we understood because of our volume, there were patients at different part of their care journey. Some were brand new referrals who are yet to be seen for a consult. Some already had been seen for a consult. They already had their workup performed, and they were just waiting for an intervention date. Some were already past intervention and needed follow-up care, such as 30-day follow-up, 1-year follow-up. Some were part of trials where they needed more longitudinal care, like 5-year follow-ups. Some of the trials included 10-year follow-ups. So we considered using our own discrete tool that we call tracking phase that helps us identify quickly where the patients are in their care journey. So these are some of the examples we did unique using just the smart form, which presents a quick summary for that patient in their care journey. Next slide, please. Now, the second part of it is checklist tasks. These are the meat and potatoes. Think of your checklist tasks as a very basic analogy of going to the shopping market with your grocery list. This is obviously more clinically inclined and more advanced. And when we looked at just how do we divide data, how can we define some of these tasks, how can we categorize it, we came up with two methodologies. The first one is a task subdivision. As I said, it's a very longitudinal care that could span years and years of follow-ups and careful decision-making. So we thought, okay, let's have a task for pre-procedure evaluations. Then there's a procedure itself, and then anything that has to do with post-procedures and follow-ups. And within these subdivisions, we have what we call task types that can exist in all these divisions, such as KCCQ. You've got to have those workups and pre-procedures, and you also got to have KCCQ 5-meter walk test as follow-ups. Same thing with appointments, same thing with procedures, ECGs, echo, cardiac CTs, and labs. With that in mind, I do have an example of tasks in action with the next slide, please. So as I said, some of these are already existing Epic tools. We leverage them and we just give them our own spin-up version on how we want to break down and how it makes sense for our department to track. These examples here kind of give you a hint of pre-intervention, pre-procedure tasks. You can see we have a pending CT consult, a pending KCCQ 5-meter walk test, some pending procedural imaging tasks. You're going to notice that the benefits of having this in the EMR using Epic is if you already had an order, if you already had something scheduled, if you already had like a flow sheet documented, the system can easily pick that up. And that's what we also call automation within Epic. So Epic already has these tools designed where if you already have an order, it picks it up, you can link it to that particular task. If it gets completed, the system automatically tracks the completion. So you're saving your staff many clicks. On the post-intervention tab, as you can see, these tasks kick in once the structural heart procedure was completed. We've designed it based on each diagnosis and even to certain degrees to each trial. A lot of the post-procedure tasks look at what type of procedure was performed, whether they're part of any trial, and it automatically spins up the appropriate follow-up tasks. As an example, as you can see on the screen, we have the KCCQ 30-day and the 1-year post-valve follow-ups. We also have 30-day, 1-year, and 2-year follow-ups. I purposely put the screenshot to also highlight how the system can reflect an overdue task. So in case, for whatever reason, someone missed looking at this patient's chart, there is that big visual red icon to alert about overdue tasks. Let's go to the next slide, please. Once we have the smart form and the tasks in the patient's chart using this tool, and we're talking about a large volume, how can we cohesively summarize it? And if we need to get to something quickly, how can we do that? We've built multiple reports, some of them based on the tracking phase, as I discussed before, where if you want to see all your patients that are still pending a consult, they were just referred in pending consult, you can run that report. All patients that are already completed their workup and are just pending scheduling an intervention, you can pull that up real quick. Anyone who's post-intervention, you can pull that up real quick. And then we have certain task-based reports. So as I said, for those of our end users who are focused on making sure a order is placed, that the order is in the system, that the patient has their KCCQ scheduled for completion, they can look at those tasks. Outside of just the clinical care team, we also coordinated with our front of the office team, the PSRs, the schedulers. We created a special report for them, and they were responsible for making sure whether it's a pre-procedure care or post-procedure follow-up, every patient does get their follow-up in time. And that definitely helped us with our 30-day post-valve turnaround times. It helped us with our KCCQ documentation metrics. And these are tools that we honestly were blessed to have. Next slide, please. From a reporting perspective, we took another step back for someone, let's say, on a care manager role, someone who may not be as involved in everyday patient care, but someone who wants a bigger picture on how the department's performing and just how the data looks like, the breakdown of data in our system. We have designed this dashboard that simply breaks down different, what I call windows, windows showing such a information such as diagnoses. If you want to get an idea of what's our volume, if patients with particular diagnoses, we can quickly jump into that report, get an idea of the patients with certain interventions, patients who are in a particular tracking phase, and so on and so forth. This is just a example of once you have the data in Epic, how much more can you build on it? We are leveraging this today to make sure documentation is completed in time. You will notice there are certain values that say no values, certain places where we say missing tasks. And that's only just to be compassionate with our staff. our staff already is spending enough time with patient care, so it is possible that they miss documentation somewhere, which is why we have this dashboard to help highlight where those documentation were missed, and so our care manager can quickly jump on it and complete those items. Next slide, please. Okay, we'll hand it back to Dr. Ebinger to kind of wrap things up here.
Excellent. Well, thank you, Kirti, for walking through sort of the second half of this care pathway that we've laid out. As Rakan mentioned, we're now being able to identify patients earlier, and through Kirti's hard work, being able to move those patients through care pathways much more efficiently. So what does this all mean when it comes to valvular heart disease care? Well, it really is a competitive advantage. We're now treating patients before they're in crisis. We are seeing a reduction in patients presenting to our emergency department with heart failure, with angina, with syncope, who have aortic stenosis that we could have identified and treated sooner. By moving patients out of that crisis phase, first and foremost, this is better for the patient. No one wants to have to come to the emergency department in the middle of the night feeling short of breath. And from a hospital perspective, this is able to improve our efficiency. Fewer urgent and emergent cases means that we're able to do this in a controlled fashion. Staff are well aware, we're prepared for the procedure, and it allows us to do scheduling that takes care of not just more valvular heart disease patients, but more patients writ large. Fewer patients in our emergency department means fewer patients who have to wait in the waiting room, fewer patients who are spending longer periods of time in the hospital. Increased access means better care, not just for patients with valvular heart disease, but for patients presenting for any and all conditions to our facility. Let's talk a little bit about the human element. We spent a lot of time today talking about technological solutions, and you heard from Rakan and Kirti about some of the incredible work that they and their analyst teams have been able to do. I want to again bring this back from a clinician standpoint. We're not replacing the clinician-patient dyad. That is actually at the core of everything that we've discussed today. What we're trying to do is free up the clinician to be able to spend more time talking with the patient about procedures, what this means for their life, and what things look like leading up to and following a procedure such as a TAVR or other valve replacement. We want that to be at the core of what we do, not a clinician in a back office trying to find the sticky note that they stuck on something to figure out when is somebody due for a procedure. By getting rid of the sticky notes and spending more time in the office, patients feel that they are better heard and get better care, and physicians experience less burnout and are able to care for people more compassionately. I also really want to stress how much of a collaboration this has been. I am so appreciative of the support that we received from Biome and from Epic and our IT team to be able to make this possible. But this isn't just an IT project. Rakan and Kirti are our clinical partners in achieving this goal, and the individuals who are on the front lines doing this are partners in the IT solutions that have helped us get to this point. Medicine is not a siloed arena. There are things that need to be done together as a collaborative, and I really do feel that this is an extremely perfect example of what it looks like when we have all members of the team, frontline clinicians, and everyone else who really make the wheels turn in healthcare delivery come together, and we can see improvements in care delivery. So what's next? We spent a lot of time today talking about aortic stenosis, but as you probably saw in many of these, we actually have started to build this out for the identification, management, and treatment of patients with other valvular heart disease conditions. Mitral regurgitation and tricuspid regurgitation are very much on the front lines. Additionally, we're expanding this out for research patient identification and how we can more efficiently identify and enroll patients in clinical trials, even if they may not traditionally have been a candidate for some of the commercially available interventions. And then let's move beyond just valvular heart disease. The cardiovascular arena is rich with interventions that we can offer to patients to improve their quality of life and their longevity. What does this mean for patients in electrophysiology? How can we identify patients who meet guideline criteria for ICD placement? How can we identify individuals who maybe had an abnormal EKG or stress test that haven't yet been evaluated by a cardiologist for potential ischemic disease? The sky is the limit when it comes to this, and it really is just limited by our imagination. We can't say enough about the partnerships we've had with Epic, our IT team, and with Biome, and we're really excited about where this technology can bring us next. With that, we want to stop and open into questions, and thank you to MedAxiom for providing us this forum to be able to share this exciting work.
Thank you all. That was amazing. I just never get tired of the story because I think it's just so impressive. For our audience, if you'd like to learn more about this, we have a white paper out there that was sponsored by Edwards. Thank you. So please go in and download that. So to go into the questions, I guess the million-dollar question here. First of all, you guys are all amazing. And I have questions for all of you, but Kirti, Epic. We feel like Epic owns the world, but the reality is they only manage 42.3% of the EHRs in the United States. So what about for everybody else? Is this feasible?
Absolutely. I would say start with understanding how you want to document your patient data and what outcomes are you looking for. For us, the major challenge was our staff, clinical staff, already knew what the follow-ups were, what they needed. They just did not have a good way to track them. And we were fortunate enough to have Epic's tool, the structured heart patient tracking tool, to use that. But we soon found out it isn't enough. Um, it's great for a starting point, but it wasn't enough. And that's why we worked hard, broke down the tasks, understood what type of discrete data we wanted documented, and how we want to display to our user. How do we want to have it accessible to our clinical staff so that they can pay more focus on the patient and spend less time on the documentation part. If there are tools out there, if you're not using Epic and there are tools out there and you're considering some of those tools, definitely go through the motions of understanding how you want data documented, how you want data displayed, and the outcomes you're trying to reach. That's what helped us.
Thank you. Um, so you guys all said the right things, right? The less clicks. We all know that non-urgent getting to patients before it's urgent is a win-win for everybody. But this also sounds almost too good to be true, right? Too easy. And we know it's not easy. It took a lot of work. In fact, it took how long to build it out? Kirti, Joe, how long do you think it took from start to end?
Probably to get where we are now, maybe what, Kurt, you think 12 to 18 months?
Easily 12 months, easily.
Yeah. And
Yes.
and that's nuts to soup. Right? Like that is like conceptualization of the idea. But along that way, there have been multiple iterations that have gone into this, starting with what we've built with the echo surveillance dashboard with Biome. That was a process that we initially started working with, and through the incredible work of Matt Isham, who helped us sort of build that out, we've had multiple iterations that have gone through. The initial systems have now expanded to allow much of the functionality that allows us to track patients within that and expand to other valvular heart disease states. With the work that Kirti and his team led, again, the number of iterations was incredible. And I want to take a moment and say that's not bad. That's actually, I think, reflective of how responsive our IT team has been and open to listening to the frontline providers of what they really need in order to do this efficiently. It further demonstrates the capacity for adaptation that this system has. This is not a one size fits all. In fact, I don't know if we talked about this. The idea behind taking this longitudinal sort of care delivery pathway comes from the OB world, where obviously pregnancy is not just a bunch of series of visits, it's an entire pathway. One of our clinical informaticists, Gabby Labad, who is an OB, said, why don't we use this care delivery pathway that we've been using in OB and apply it to valvular heart disease care? Obviously, different disease states, but the same idea is what carries across. And I think that adaptability and iteration are strengths, not weaknesses. Does it add a little time? Sure, but it makes sure that you get the right solution for the right healthcare organization and for the right patient at the right time.
That's great. In fact, that's what gives me confidence that other systems, non-Epic systems, can do the same things. Because guess what? They're having babies too, right?
Exactly.
So
And they
hopefully,
have patients with valvular heart disease.
right. So again, that's it's a commitment, right? It takes time, and we need patience, and you need all the right folks at the table. And as long as everybody's aware of what they're in for, I think it's the long-term solution far exceeds the commitment that's given up front, right? It's worth it. And Rakan, going over to you, there's a number of other programs, systems out there, tools that are also, I'm sure, also reasonable. But I know a lot of the hurdles that other companies have is because they connect to the EHR and the time, the ability to do that in this, risk adverse society right now takes forever. So the fact that you guys sit in the cloud and on top of the EHR and you're not connected directly sounds amazing. But what in fact is the realities of that? How long does it take you guys to connect, and how real time is the data?
Yeah, that's a great question. So I'll answer your second question first, which is the real-time piece. I mean, we end up getting connections, flat file transfers on a monthly basis. We find that anything quicker than a month is probably splitting hairs, but we do set up automated feeds, flat file transfers from the Epic or from the imaging workflow systems themselves. So really, the lift to get from a customer to sign on the dotted line is just about identifying who has access to the back end of the workflow, and then they develop the query that pushes that data to us every month. So we can get data as quickly as a couple weeks to a month after we sign on the agreement. Now, we also recognize that not everyone has the resources and the EHR infrastructure to support this as well. And so we have also partnered with Dr. Mark Russo out of Rutgers to develop our own workflow system that is really targeted towards the folks who don't have the ability to build it internally. So there are options out there, including with what Biome has helped develop to help bring that workflow to the hospital. And the primary reason for that is because from a process improvements perspective, we really care about time to treatment. And so what we want to do is we want to measure the timestamps and the gates between the identification all the way up until the patient goes to the treatment table. And for us, being able to document those timestamps and the delay between each stage allows us to offer up our playbooks to our customers to show them exactly how they can tackle certain problem statements. So we do have a solution that's a little bit less intensive as the homegrown solution. But of course, the benefit, as Dr. Ebinger has mentioned, with a homegrown solution is you can really make that bespoke to your own hospital. So there are pros and cons to each.
Okay, that's the right answer. Good. And thank you for bringing up Dr. Russo. He was also very helpful in helping us to also understand and learn. And some of the takeaways from him I remember him saying, it stuck with me that, again, doing the procedure is the easy part, right? It's getting the patient to the cath lab. That's the hard part. So that's a telling story of all the obstacles the physicians have, the patients have, the staff have. So this is all about building a system that allows to expand with growth without throwing people at the solution, right? Because we know that's not the solution. We just don't have the margin, the budgets to do that anymore. And the reality is somebody leaves and suddenly the whole system breaks, right? So this to me is proof of concept that you can build and grow without adding new FTEs at the same time without adding work burden to people too, right? Because often that's what the assumption is, you're making me work harder. And that's not the case. It's truly the whole work smarter concept, right? So that's a lesson, taken in this whole story that we're telling here. And the other thing is that I wanted to go back to Kirti. We've all been part of large hospital systems, and in this case, it's Cedars. Everybody assumes that Cedars doing the right thing. They have the money, first of all, right? So it's way easier for them than for everybody else. But we know we all have obstacles, even in these large academic medical centers, right? They're not throwing money at you, Joe, every time you walk in the door to build something, right? So how do you get
I've asked, but they haven't started yet.
right? Let me know what the magic word is, right? That allows for that to happen. It used to be NIH, but that doesn't work anymore, right? So tell me, how is it that you were able to carve out your time, right? How did this become a priority to build this? Because again, we're talking 12 to 18 months of your time was suddenly devoted to working for the cardiovascular group here. How did that happen?
Yeah, that's a great question. In reference, I would say a typical Epic implementation for a hospital, a small to medium sized hospital, takes 12 to 18 months. And here we're talking about just one program in a large hospital taking 12 to 18 months. It goes back to our leadership in the cardiology side, understanding that this is not something to be rushed with. So even though it was myself and a couple other folks, we had the benefit of time. We already understood that we're not in a great position. We want something that improves the patient care, improves our documentation, brings in efficiency. Why rush it and come up with a solution that feels half done? It allowed us the time for 12 months to 18 months to really, as Dr. Ebinger mentioned, launch a pilot phase, go through iterations, understand what other data we needed to track, how was it impacting the nursing staff? How was it impacting our scheduling staff? How was it impacting our clinician staff? And so, as I said, consider this more as a iterative model. Keep growing and building and growing and building, and take your time with it. That's what we did. For those who may feel that you may not have the opportunity of time, the out of the box solution from Epic works great. It works great. It is designed to be plug and play. Of course, there's going to be the learning curve of training your staff and how to document it. But as I said, we tried that. We needed more, and so we thought, okay, we'll put the time in, invest our time now for better returns in the future. And we're one great living example of that.
Yeah. Thank you.
Can I add one piece in there that Kirti mentioned is, Kirti was this driving force from an Epic perspective, but I can't stress how important it is to have a clinician champion who's going to help with not just being able to provide that feedback, but also be the support for the other clinicians who are going to be using this. Stacy, who's one of our APPs who works in our structural heart clinic, really served as that role. She was there not just providing very frequent, regular feedback on how the product was being designed. But then it was also the person who's physically in the clinic when Kirti or what member of his team couldn't be, helping them figure out the new care pathway delivery. Absolutely vital to have that person, not just to be a cheerleader and help folks get behind the change, but to help on the day-to-day process of this is how the care pathway is going to look now. And once that is set and running, it's amazing how quickly and how it becomes embedded into workflows.
Yeah, that's important. And thank you for that. I think we're running out of time. I'm looking at really quick. So I think just some closing words, Rakan. I just want to emphasize that for those who didn't pick up on that, all these echoes out there were already there. They weren't new echoes. It's patients that came in through the ED for something else. And for some reason they ordered an echo. In some cases it was an echo for a general cardiology visit or maybe a primary care visit. So this stuff was already out in the system, right? So to me, that's I think that's the important message here is you're increasing your volume, but it's better for the patient actually, right? Patients don't know they need you until again they're having chest pain and coming in on Saturday night, right? And then that becomes urgent, and then it's problematic because then they're symptomatic and it's too late, right? We've already caused a lot of avoidable damage. So Rakan's concept of grabbing the patient before they present is actually a lot of the magic sauce here, right? Because then you can work the patient into the system and they get seen when they're supposed to be seen, and eventually make it to the procedural area, which is, obviously what everybody's looking to do is grow a program. So all around, I think this is an amazing case study. You guys did brilliant work that I'm hoping other people learn from, are able to model it. I'm hopeful you guys are available if people have questions. Because again, I think it's a tip of the iceberg, and this is actually how we should be thinking about taking care of patients, right? Again, cardiology, we're used to the STEMI calls and the cath lab, red flags, but it shouldn't be that way, right? The day we don't need STEMI call anymore is the day we've actually, improved systems and actually fixed all the problems. And you're going to do that for us, Dr. Ebinger. So thank you all. Any last thoughts, Dr. Ebinger?
Anna, I apologize, we did have one question come through. Does the Biome tool link the identified patients to the Epic patient tracking tool?
So we track EMPIs and MRNs. It really depends on how you implement the workflow. The list is fully exportable. As I mentioned earlier, it's designed to stay out of the EHR because then you're talking like a 12 to 18 months IT queue to get the project stood up. But our customers download the case list that has all the patient identifiers that we can then upload into the workflow tool.
And to mention that is also a purpose, not a quirk of the system.
Right.
Cedars, just like many organizations, we are a pluralistic model. We have providers who are full academic faculty like I am. We have private practice docs, and we recognize that the patients who are coming through have multiple different providers, and those providers may have different referral patterns. We did not want to step in the way of providers. We did not want to get in the way of referral patterns. So this is not a quirk, but a purpose in that we are able to keep that out of the EHR, inform the provider and say, we as the institution recognize that this patient may qualify. would you like them seen by us, or are you going to manage it on your own? And so it's a great question. It can be set up either way. We have purposely done it this way because we want to be cognizant and aware of that patient-provider relationship.
Politics. Even Cedars hasn't figured out the politics.
I'll let you know if we do.
Awesome. Well, everyone, thank you very much to all of our members who joined us. Thank you very much. I hope this was helpful. I hope it was educational, and I hope you have more questions for the future. We look forward to seeing you guys at our next webinar.
Thank you to MedAxiom for sharing this important work.
Absolutely.